I'm Dr. Cubillo, one of the partners at Pain Institute of Southern Arizona, and we're very excited tonight to chat about a good topic on diabetic nerve pain. And why is it that we're excited? Because we've treated this syndrome for decades, and we haven't had as much success as we think. You know, we give medications, we try these topical treatments, and they're not very effective. So we're pretty excited with some of the data and research that's come out to treat diabetic nerve pain. So I'll be doing the first half of the presentation, then my partner, Dr. Bailey, will be doing the next half. Any questions along the way, we can wait until the end, and we're more than happy to answer those questions. So let's get started. A few things about myself. Locally, went to the U of A for medical school, went out to Scottsdale to do a residency in anesthesiology at the Mayo Clinic, and then went out to the Harvard system to do an interventional pain fellowship, and then came back to Tucson since 2016 with the group. And then my medical partner here, Dr. Bailey, is part of the 3M Club, not the Minnesota Mining and Manufacturing Company. Very close, though, at the Mayo Medical School in Rochester, Minnesota. I think he brought the weather with him today. He said, well, gee, it's too cold in Rochester, Minnesota, then went to Scottsdale. So didn't stay at the Mayo Clinic at the mothership. When at Scottsdale, we've been colleagues for the last decade. He trained at Mayo Clinic, chief resident at Mayo in Scottsdale, then stayed on for an interventional pain fellowship, and has been with the group since 2020. So a few things. Before we get started on all the details of the lecture, I'd like to share our vision statement with you all. Through compassion and innovation, we will make a meaningful difference in the lives of individuals and communities. So why is that important to us? This is true to our core values, our core existence in our medical group, because you truly have to have both of these factors to be able to have successful outcomes. So think about, a doc that has wonderful compassion, great physician-patient relationship, but unfortunately doesn't stay up to date with the data, doesn't stay up to date with technology. Those outcomes aren't going to be as positive. And the same thing goes to, you can have a wonderful physician that has a lot of technology in their toolbox, but the patient-physician relationship isn't solid, and their bedside manner could be subpar, and that relationship doesn't just thrive. So you have to have both, and we pride ourselves on achieving both of these goals to improve patient outcomes. Another thanks for this presentation is working with the Nevro Corporation to be able to help tonight with this PowerPoint as well. One question for all is, do you have pain that feels like burning? Is it tingling, cold, numbness in the feet or legs, or even the hands? May I have a show of hands on that? Good, so the majority, and for many different reasons. It may not just be diabetic nerve pain. It may be a little maturity in life, a lot of miles on those feet. It could be chemotherapy-induced neuropathy. We see a lot of nerve pain from chemotherapy, so we always ask patients that we're seeing for diabetic nerve pain has there been chemo involved in this situation? And also folks that have worked with like heavy metals and things, so any toxin exposure. So I know this is diabetic nerve pain, but it's neuropathy in general. So big show of hands for the burning, tingling, cold, numbness in the feet and legs. The other thing is not just pain, but does it limit your functionality? What does it prevent you from doing? Does your pain limit you from doing some or all of the activities you enjoy? Simple things like, walking your dog or walking around the neighborhood. I'd like to see a show of hands on, does it limit what you want to do in life? Okay, and very, very similar representation. Can you describe what the neuropathy prevents you from doing? Sleeping. And that's a big one, is sleep. But then remember that sleep interruption then feeds into the pain cycle. So it's pain, insomnia, and we just can't get a grasp on controlling the pain or the sleep. It's just a cycle. And then you just Then it reduces all of the functionality. Then you're like, gee, I'm tired. And now the doctor's giving me some medications that makes me more tired. And then I can't function. So then it's a downhill battle. The goals, the objectives for today are, what is causing the pain? What really causes neuropathic pain or nerve pain? Some common medications, treatments for it, some proven treatments for PDN or painful diabetic neuropathy, and what are some of the next steps that you can take to take control of the pain. Before we get into a lot of the technology of it, how common is diabetes? And we all know it's a very common disease in the US and worldwide. What are the statistics? And these are probably a little bit underestimated, but roughly about 37 million folks in the country with diabetes. And 1 in 10, that's 1 in 10 people in the US have diabetes. That's a lot of folks. So then, out of these patients, what's the percent that have some kind of nerve pain? A quarter of those patients. That's a lot of patients who are struggling with nerve pain. So 25% of the 1 in 10 population has peripheral or painful diabetic neuropathy. Now, roughly 50% of those patients with diabetic nerve pain fail conventional medical management, some of the medications that we'll talk about. So we think as physicians, as providers, that giving these nerve pain medications work. They do. We still keep prescribing those meds because some of our good outcomes, great, I got 90% relief with the gabapentin, wonderful. But the actual number needed to treat a patient to have a successful outcome is actually pretty high. You almost have to treat 1 patient for every 10 or more to get a success. So that's why a lot of patients don't get the response that we want. Is actually the statistics are about 45% don't respond. So that's not the best statistics for those patients that respond to medications. And we'll tell you a few reasons here shortly. We've kind of came in right into painful diabetic neuropathy, but we haven't really defined it. We said 25% of the population with diabetes has diabetic nerve pain. Why does the sugar cause nerve pain? So think about glucose at high levels as a toxin. It's saturating, it's reducing how the nerves function, meaning that when a nerve is exposed to sugar, it's slowly deteriorating on how these nerves send information from one nerve to the other. So it's truly a toxin at high levels. This is an interesting number, is that it can happen 5 to 10 years after you show symptoms of diabetes. So a lot of patients that I see had an undiagnosed diabetic situation where then they go to the primary care and their A1C is like 10 or 11, but by that time, years later, the burning in the feet, the hands, the eye issues, the kidneys, 5 to 10 years after you show symptoms of diabetes. That's an interesting statistic. This is a little bit more illustration on the nerve pain. So I have an illustration of these cables or these wires here that the glucose or sugar, as the toxin, it basically peels away the insulation of the nervous system. So think about one signal getting to the other area with not much insulation. There's going to be these short circuits in the system and saying pain, 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 numbness, tingling, burning, cold, and every nerve is made differently, meaning we have some patients that have the cold, some patients have the pins and needles, some patients have the ants crawling on them, is that you can have all these different kind of symptoms. So the other one is this slide. I love this slide because this happens to me a few times every 5 years or so when I'm putting Christmas lights. Number one, it's in the garage and it's all messed up and they're tangled. But then you go in, you put it on the tree on the outside and you plug it in, and then you have about 30 bulbs that are out. You say, gee, what do I do here? So you're trying to find out, okay, this lights, this doesn't light. You try to get a new bulb and you do it, and you cross your fingers, your toes, and eyes, and it still doesn't work. So think about this as a nerve, is that you have all these short circuits. One area is not sending signal to the other, and then the spinal cord sees it and says, gee, what's going on here? So then it's firing signals acutely, and then you get into this chronic pain stage, and then the brain starts changing that says pain, 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 pain. That's why a lot of this is hard to treat, because once we let this linger on, then the brain starts changing. It creates a chronic pain situation. As I stated earlier, nerve pain can feel different. My feet can't warm up. They're very cold. They change colors. I feel like I'm walking on hot coals all the time. I hear that a lot in the clinic. The feet are numb, but painful. It's like, okay, how could it be numb and painful? Remember, that's that short circuiting. The cables aren't sending the appropriate information to the spinal cord. The pins and needles sensation, ants crawling on me, all these different things. Why? Because the nerves are being destroyed and irritated at different sites. We've defined painful diabetic neuropathy. We've kind of mentioned what we do to treat that, but let me get a little bit more detail in what some of the medical treatments there are. The big ones are the Lyricas and the gabapentins, so pregabalin and gabapentin. I'm curious how many patients in the room have tried gabapentin or pregabalin? Probably everybody in the room. These medications, specifically gabapentin, was originally made in the late 80s, early 90s for epilepsy, for seizures. Now think about it, is that when I describe it to patients, they say, epilepsy, so I'm taking an epileptic drug. Well, think about epilepsy. These nerves are angry, firing in an epileptic brain. So we found in those studies that patients who had nerve pain got a little better. Why is that? Because the nerve pain is hyperactive. The gabapentin is truly just calming it down. Now, gabapentin and pregabalin are cousins. Just because one has a side effect doesn't mean that the other one isn't going to have the same. But how effective are these? 45% of diabetic nerve pain, they don't respond. But we still keep trying to see if this would help that specific patient. The other ones are the antidepressants. Cymbalta. Has anybody tried Cymbalta, duloxetine, for nerve pain? When it works, it works. But when it doesn't, there's a few side effects to it. A little sleepiness. Some patients say, I'm having nightmares, and I'm having GI upsets. Those are some side effects to the Cymbalta. But yes, it's approved for neuropathy, but there are a few side effects to it that you have to take into account before we prescribe the medication. The other ones are these topicals. There's this caspacin and lidocaine. Anybody in the room tried topicals for the neuropathic pain? Can somebody comment if it's actually really helped you?
No.
Okay, and the compounded creams are very expensive. If we've tried, I've given it to patients, prescribed it, but then when I find out, geez, how much each tube is for every month, I said, well, we're not going to do that anymore because it's too expensive and it's not working. So, because in the compounded creams, you can put all these together, gabapentin, prilocaine, all these different things, but long-term, it's just not a feasible option. So then comes spinal cord stimulation, which Dr. Bailey will talk about soon, and that is a long-term sustainable option, non-medication, to help with diabetic nerve pain. Speaking of the side effects, we touched on that. Short-term memory loss, some cognitive decline, some slowing of thinking. I had one patient I just saw before I came here said, you know, the Lyrica was just making me feel a little bit different. A little bit, I was trying to get my words out, but I couldn't get them out. I felt a little bit strange. Fatigue, I'm tired all the time. Not only do I have sleep apnea, but I'm just tired because of the medication. Sleep apnea patients usually have some tiredness throughout the day. My female patients hate me for this one, the weight gain. When we're 5 pounds heavier, I'm yelled at and said, Dr. Cubillo, you've caused my 5 to 10 pound weight gain. That is a side effect, is the weight gain. The dizziness, brain fog, and the nightmares come with the Cymbalta, not the other ones. Opioids. How likely is a narcotic going to help diabetic nerve pain? And the answer is very minimal. One class of patients in this whole opioid epidemic that has seen massive doses of narcotics have been the diabetic nerve pain. Why? Because other meds don't work. So the primary care, not blaming primary care, but the providers say, well, gee, 10 years ago, geez, nothing's working, so we should probably give more of the oxycodone, give more of the morphine. It's not working at 15 milligrams 3 times a day. Well, let's give a little bit more. And it just doesn't work. And then over time, with higher doses of opioids, you can actually worsen the nerve pain over time. And we know that from many studies out there that if you give too much, it could actually induce worsen of pain. Now, certainly not against, short-term opioids, etc., maybe to get you through for a longer-term option like spinal cord stim, but it's just not the best choice. Getting through the side effects of the medications, now there's an FDA-approved non-drug treatment option for painful diabetic neuropathy, and that's spinal cord stimulation. And Dr. Bailey, my partner, will get right into it and give you the details of it.
Well, excellent. So, like Dr. Cubillo said, I'm Chris Bailey, one of his partners and longtime colleagues. We're going to talk about what exactly Dr. Cubillo is describing there as spinal cord stimulation. And what is spinal cord stimulation? Another term for it that's described is neuromodulation. So we'll use these terms interchangeably. One of the things that neuromodulation leaves out is that the spinal cord stimulation is directs stimulation or electrical patterns that go in and basically block pain in the spinal cord. And there are other forms of neuromodulation. It's non-opioid. It manages chronic pain in different ways, and new research has come out with really promising studies that show prolonged, consistent, excellent pain control, especially with painful diabetic neuropathy. It was first used back in the 1960s, so this has a long history of safety and success for a lot of things, and originally it was really developed for failed back surgery pain that went down into the legs. And what eventually kind of developed into is a more robust system and a more robust technology to treat back pain and leg pain, and then now peripheral neuropathy related to diabetic complications. The other thing that this slide talks about is that there's a lot of people that have had this procedure done, this technology implanted. In fact, 34,000 to 35,000 patients each year have a spinal cord stimulator implanted. Neuromodulation, if you look at what that is on the right, that is a diagram showing a slice of the spinal cord. And on the far right, there's a finger getting a painful stimulation of putting their finger on a nail. That pain signal goes through to the posterior dorsal horn. That just means kind of the backside or dorsal fin. All this fancy stuff, but it basically goes in and gets transmitted up through the back of the spinal cord to where it goes into the brain. What spinal cord stimulation does is it sends these signals, and you can see at the very top here, that back there, those black circles are sending electrical signals that are intercepting those pain signals as they go up the back of the spinal cord before they get to the brain. And what this does is delivers that mild stimulation to the nerves, minimizing the sensation of pain, and then also allowing other signals to get back up. And we thought that's maybe what's happening. We're decreasing the noise, and that other signals of sensation are getting better over time. And then it intercepts those pain signals before they reach there, and they diminish that feeling of pain. As we move on to this next slide, it talks about, what is the process of getting spinal cord stimulation? Because we have to see, is this the right choice for me? Patients that are getting good relief with their medications and are not having side effects might not necessarily be the best candidates because they're well treated, but people that are here today are probably not well treated because in terms of the efficacy of these treatments, you're still continuing to have burning, numbness, pins and needles sensations. One of the important things is making sure that what we would be treating is actually diabetic peripheral neuropathy. So we want to confirm that you've got a diagnosis of diabetic neuropathy and that there's no contraindications to proceeding with that. Sometimes there's different things, both medical and then psychological, that might not make you the best candidate. Then we have a meeting with you and we talk about, gosh, what are the options for why you might need neuromodulation or spinal cord stimulation? And there's a lot of different reasons for it. One of which I mentioned before, failed back surgery syndrome, radiculopathy, different non-surgical back pain, and then peripheral neuropathy related to diabetes. Now, the psychological screening I kind of mentioned there, one of the things that was found when studying spinal cord stimulation was that individuals with severe mental illness or maybe kind of misguided ideas about what spinal cord stimulation does might not be the best candidates for this because it might not be as effective for those individuals, or they might not be satisfied with the amount of success that they've had with it, thinking that, oh, this is going to get rid of all my pain everywhere and I'll be able to play the violin even though I've never seen a violin before. Those are the people we want to make sure that we're setting up expectations and that this technology is great, but it's not a cure-all for everything. The next part of it, if we deem and look at this and we say, gosh, you're a great candidate, we want to move forward with this, everything goes through wonderfully, we move forward with what's called a trial. And a trial is a 7-day test to see where you test drive, basically, spinal cord stimulation and see if it works for you. We temporarily place leads through the skin, and the term we use for that is percutaneously. And it's outpatient, so that's a nice thing. You don't have to go in the hospital, you don't have to stay overnight. You get to come in and use kind of minimal sedation while you're breathing on your own, so it's very safe to put these leads in. And those leads, you can see on the right side, there's 8 contact leads, this little metal on the ends of a lead, and a lead is kind of like a spaghetti noodle, and it's like an al dente spaghetti noodle where it's flexible but somewhat firm. And that goes up in through the back, and we're able to drive that just through the skin. And it goes up into the back, approximately where your shoulder blades are. The trial lasts 7 days, and during that time period, we check to see whether you're getting relief, we change programs, we do lots of things, and there's interaction both with our team and then also with the team, in this case with Nevro. Sandra's in the back, and the other members of the team work really closely with us, and they're valued partners in the process to make sure that you or any other patient is getting the relief that they need in optimizing the therapy. Successful goals are defined as improved quality of life, which I think we've defined as, the things that you want to do. Are you able to go out and walk? Is your sleep improved? Things like that. And then a 50% or greater reduction in your pain. Now, your pain, as we defined, can be lots of different things. It may not be that putting your finger on a nail. It could be that burning sensation, that pins and needles sensation, all those things that are associated with painful diabetic neuropathy. The implant, if that's a success and you meet all that criteria, we move forward with another outpatient procedure. So an implantation is what we call a permanent implantation of the device and the leads underneath the skin. It's performed under sedation as well, so you're still breathing under your own, so it's very safe. You don't have to do general anesthesia. And it's outpatient, so you come into a surgery center, you have the procedure done, and get to leave that same day, hours afterwards. The leads are placed underneath the skin. So not only do we place them kind of percutaneously or through the skin, but then we place those leads underneath the skin to where a pocket goes. If you notice in that illustration there's a battery pack, or what we call a generator, over the hip or above the hip, kind of between the hip bone and the ribs. We place that in there, and that's a spot that makes it comfortable for you so that your belt line doesn't rub against it. And when you're sitting in the car or a chair, it's not going to bother you. The components of the system that we're describing going in are the leads, and we talked about that. Those are the thin wires, basically. They're insulated, and they go up into the back. And they're what conveys that electrical stimulus from the generator up to the spinal cord. The generator, or IPG, which is internal generator, that's a small device. It's about the size of a pacemaker, and that goes into your back. The Nevro system stays in the back and can last for up to a decade, is a rechargeable device that you just charge through the skin. So again, you don't have to put your finger into a light socket or an outlet to charge this. It just works as simply as sitting, watching television, or reading a book while this charges on your back. The patient controller, and that varies, but most of the time that just goes right through your phone and can communicate with your generator allowing you to change programs, change the amplitude or energy that you're applying towards your back pain or your leg pain or your peripheral neuropathy. So it really puts the power of this technology in your hands to really control your pain. Now, this is kind of the game changer here, that many of these technologies and things come out and they're kind of vague and everybody says that they're kind of the same as everybody else. And for the most part, most of these technologies and things that are offered, it's like a generic thing. If you offer a medication and we say duloxetine and Cymbalta, they're the same medication type of thing. And one of the amazing things that's come out is that the American Diabetic Association and the American Association of Clinical Endocrinology have both come out in their clinical statements stating that spinal cord stimulation is an excellent, durable treatment for painful diabetic neuropathy. And they specifically call out high frequency, which is 10,000 hertz spinal cord stimulation, which is Nevro's system. So what they call HFX. A non-drug solution. HFX has kind of changed. It used to be HF10, and then because it offers so many other things, they've kind of expanded that from a branding and marketing standpoint. They've studied this after implanting these and having 2 years of durable data have shown that patients on the average get 77% pain relief. And they're showing that upwards of between 80 and 90% of patients that participate in this get relief as well. There's nothing that compares to that kind of result in terms of treating painful diabetic neuropathy. As Dr. Cubillo said, patients on medical management, a number needed to treat is 10 to 15 patients before you get one that starts working. And of those patients, only 45% maybe get good relief from it. And that's durable. The amazing thing is over 2 years, that doesn't dip down. People don't lose efficacy of it, which happens with medications. Nevro's also been around for a long time. Over 100,000 individuals have had this technology put in their body, implanted for their pain, and have had excellent pain relief. So here's the other thing, 8 out of 10 patients enjoy long-term pain relief with this, and that their average pain score, so if you look at this, 7.7, if you're on a scale of 1 to 10, what's your pain? As we go through that, you hear that all the time. It's really difficult with diabetic neuropathy to put a number on your pain, because it's different. Sometimes it's pain, sometimes it's something else. But when it was graded, 7.7 was the average. So that's a severe level of pain. After implantation of HFX, they received pain scores or pain reports of 1.7, and that's significant. I mean, there's no getting around that. That's an excellent improvement of pain, and it's durable over 24 months. And then there's also additional information that's coming in as well, which I'll speak about shortly. I don't know about you, but you look at the number like that, pain of like 7 or 8 out of 10, going down to 1 to 2 out of 10. I think you would all agree that that's pretty excellent. The other thing that's been found, and it doesn't really, we're not highlighting it right now, but they're also finding data, and this is investigational and early, but people are getting improved sensation in their feet as well. So not only is their pain going down, but they're feeling things better. Their cold sensation, their hot sensation, their proprioception, which is a fancy word for balance and sensation of feeling things, has improved as well. And they're looking into why that's happening, and I won't touch upon that because it's early enough that we're trying to figure out why that happens, but we know that that is happening as well. So I think that's a really promising thing that's coming up, and it's kind of a secondary thing that we look for. Pain improvement is really the important thing. That's the thing we focus on. As a healthcare provider, I find that very exciting to be able to actually improve people's function as well. This is some quotes from individuals who have HFX implanted, talking about the huge impact on their life and the things they're able to do with their children, their grandchildren, as well as their sleep. It's been transformative for the patients that we've implanted this for. As we look through this, we'll touch back again now. Are you a candidate possibly? Do you have diabetes? Do you have diabetes-related neuropathy? Have you tried 2 or more medication classes? Do you have continued pain in your feet or legs? And is your A1C 10% or less? That's a key thing there, but it's one of those things we look at to make sure that your glucose is well controlled, because we're concerned about putting this device in. If it's too high, we're concerned that you may get an infection with it. And that's the last thing we want to do. We don't want to harm people. We want to help them. So next steps, that was one of the things Dr. Cubillo mentioned. You've sat through this whole thing. You've tried to listen to me. You try to hear me if you're in the back there. And, what are my next steps if I want to do this? We can schedule you an appointment for sure today. We're going to put a number up here too. And I think Erica was here earlier. She kind of heads up our appointments. We would evaluate you and have that conversation about what we might be able to do to help you. We can discuss the treatment plan then, and then get you back on the road to your improved quality of life.